Hello, my name is Eddy Fan. I'm an intensivist from the University of Toronto. I want to thank the organizers for the opportunity to speak today on extracorporeal CO2 removal, or ECCO2R, moving from specific diseases to VILI prevention. Here are my disclosures. I won't be speaking specifically about any devices in my talk today. So the topic for discussion today is extracorporeal CO2 removal. As people in the audience may be familiar, this is a type of extracorporeal support that typically requires lower flow than ECMO, VV ECMO, and currently mostly as a research indication as a way to manage hypercapnia that may occur from the delivery of lower intensity mechanical ventilation as a way to facilitate the delivery of more protective mechanical ventilation in patients with ARDS. It's also being studied, as you might imagine, in types of hypercapnic respiratory failure, particularly those complicating obstructive lung diseases like asthma and COPD. And again, as the talk today focuses on moving from specific diseases to VILI prevention, really just going to quickly highlight that it is an active point of investigation in many indications for hypercapnic respiratory failure, again, particularly in the realm of acute exacerbations of chronic obstructive pulmonary disease, either as a strategy to avoid invasive mechanical ventilation in those patients failing non-invasive ventilation, or to rapidly facilitate extubation in those who do decompensate and require invasive mechanical ventilation as a way to minimize the need and the harms in this patient population from the use of invasive mechanical ventilation. But today we're moving away from specific diseases to the idea of extracorporeal CO2 removal to prevent VILI. And perhaps this is a natural progression along the timeline of extracorporeal support, where in the early days, it was really seen as a strategy to rescue the most dire cases that were failing conventional therapies. And over the recent years, we've used it to provide gas exchange support in a variety of contexts and provide along the way more protective mechanical ventilation. Now really we're talking about the idea of, could something like ECCO2R be used as a primary strategy to be used as an adjunct to mechanical ventilation to again facilitate lung and perhaps even diaphragm protective mechanical ventilation, and even prevent the idea of patient self-inflicted lung injury in some patients. And that's really an active area of investigation today. And the rationale for this, just to quickly go over the idea, is that could the use of extracorporeal support as an adjunct allow us to deliver, again, lower intensity of mechanical ventilation? Because there's data suggesting that delivery of lower intensity mechanical ventilation may lead to additional benefits. So on the left, you could see post-hoc data from the ARDS network by Dave Hager and colleagues showing plateau pressure and day one plateau pressure and mortality. And you can see the lower the plateau pressure, the lower the mortality. So again, perhaps the idea that if you could slide patients down this plateau pressure curve, that they might have less resultant mortality. And similarly, these data from Dale Needham's group in Baltimore showing a dose-response relationship between tidal volume and 2-year mortality. Again, we knew from the ARDS network study that 6 mils per kilo was better than 12 in terms of mortality, but perhaps 5 is even better than 6 and 4 is even better than 5. So again, the idea that lowering tidal volume as another strategy or target for decreasing the intensity of mechanical ventilation may lead to better outcomes in these patients. And we have some pilot data that suggests that this physiologic rationale can be achieved and can lead to benefits. This is the Supernova pilot study, which was sponsored by the European Society of Intensive Care Medicine and sponsored by the International ECMO Network. So a proof of concept, a safety and feasibility study, 95 patients in 23 centers around the world. The target here was, again, the idea of looking at moderate ARDS patients who we might try to deliver more protective mechanical ventilation. These patients had their tidal volume as the main intervention reduced from 6 mils per kilo to about 4 mils per kilo predicted body weight. PEEP was adjusted to maintain and expiratory lung volume. And the idea here was to use the CO2 removal to maintain a reasonable PaCO2 and pH. Safety and feasibility were the main outcomes here. And indeed, by the use of this low flow CO2 removal device, the vast majority of patients were able to reach the target tidal volume. Most had a concomitant reduction in plateau pressure, driving pressure, and an increase in PEEP. Really no significant changes in the physiologic parameters. There were, importantly, some serious adverse events and device-related complications, again, suggesting at least that this strategy of ECCO for VILI prevention by reducing the intensity of mechanical ventilation is possible, but we need obviously a larger randomized control trial to see what the trade-offs might be between adverse events and the possibility of improved patient outcomes. And indeed, this was actually the target of a very large planned randomized control trial called the REST study, led by James McNamee and Danny McCauley in the UK. It's recently stopped. And while we're awaiting the publication of the results in a manuscript form, these results were actually presented last month at the critical care reviews meeting. So for those who are interested, can see the results online. But this trial really wanted to help us test that hypothesis that could extracorporeal CO2 removal help us deliver lower intensity mechanical ventilation and therefore prevent VILI, translating to better outcomes in patients with respiratory failure. Again, the manuscript is forthcoming, but the results that were presented in January showed that the trial, which was originally planned to enroll over 1,100 patients, actually was stopped early after 405 patients were enrolled, both for futility as well as the possibility of harm, without a difference in the primary outcome of survival, really no significant difference in survival, and actually slightly fewer ventilator-free days in the group randomized to ECCO. Importantly, along with the lack of a difference in the primary outcome, there were actually worse secondary outcomes and more adverse events in the ECCO group, despite this reduction in mechanical ventilation intensity with ECCO. They indeed managed to get patients down to about 4 mils per kilo predicted body weight tidal volume, with a small reduction in driving pressure of about 2 centimeters of water. This study, again, while we're awaiting the final publication, at least does not seem to support the routine use of ECCO for this indication in this setting. And perhaps, again, once we have more opportunity to review the data, perhaps there is some heterogeneity of treatment effect, and we'll have to see if there are various subgroups where we might target future investigations for this therapy. Importantly, because of the increased adverse events, and because one of the reasons to stop the study was for feasibility around safety and the possibility of increased adverse events, particularly bleeding and intracranial hemorrhage, raises the question of, to achieve this level of mechanical ventilation intensity reduction, do we actually need extracorporeal support? And do we really need to go back to the drawing board based on these results as to how we might best use ECCO in the setting of VILI prevention? I just raised these very interesting data here from Jean-Christophe Richard and his colleagues, showing that at least for the degree of tidal volume reduction in the REST trial, in a lot of these early pilot studies, which focused on reducing tidal volume to about 3 to 4 mils per kilo, it seems that in some moderate to severe ARDS patients, you can actually achieve this reduction just with conventional mechanical ventilation alone and without the need for ECCO. So in these 35 patients, they were able to reduce tidal volume to 4 mils per kilo. They had to increase respiratory rate to maintain a reasonable pH, and they set PEEP according to the PEEP-FiO2 table. 2/3 of these patients were able to achieve the tidal volume goal by day 2. This also led to a concomitant, again, reduction in driving pressure of nearly 4 centimeters per water on average. But importantly, some of these patients did develop severe complications, including cor pulmonale and some transient severe acidosis. So again, at least raising the idea that for this magnitude of reduction in mechanical ventilation intensity, a good number of patients may be able to achieve this without extracorporeal support, but at the risk or consequence of the possibility of some complications and some hypercapnic acidosis. So the idea that, should we, based on these results, abandon ECCO, do we need to tailor our intervention or how we want to use this device better in this group? So perhaps we need to focus on a different patient subgroup, for instance, forgetting about PF ratio and targeting the intervention at those at the highest risk for VILI. There's been some nice work from my colleague, Ewan Gallagher and Art Slucky, suggesting perhaps those who have the highest dead space and the worst compliance, those might be the patients who could benefit most from a reduction in mechanical ventilation intensity and VILI prevention. Do we need a different dose? The REST trial and some of these other pilot studies looked at short-term use of extracorporeal support. Perhaps we need to keep it for a prolonged period of time because the exposure to VILI is continuous and we need a different dose. In the REST trial, nearly a fifth of patients had it discontinued due to device regulations around its maximum use. And we might need it to continue for a sustained reduction in mechanical ventilation intensity. Again, many trials have looked at targeting lower tidal volume, but perhaps we should think about different targets that might lead to better results. For instance, targeting driving pressure or mechanical power. And again, the idea that perhaps we need a strategy that leads to a greater and more sustained reduction in mechanical ventilation intensity to see that translate into differences in patient-important outcomes. And I think the key thing here is that since we're talking about ECCO trials, this is an adjunct to mechanical ventilation, and how the patient continues to interface with mechanical ventilation still matters. So we have some data, for instance, suggesting that driving pressure is important. Again, you might imagine, looking at the left panel, that the greater the reduction in driving pressure, the greater the improvement in patient outcomes, and that actually this effect is relatively stable over time. So again, leading itself to the idea that using extracorporeal support to reduce driving pressure over a longer period of time, or a sustained exposure to lower driving pressure, may be the key to preventing VILI and leading to better outcomes. And that looking at effect modification by severity of lung injury here, measured by PF ratio, suggests again that the most compromised patients with the most severe lung injury might benefit from this strategy the most. So again, this idea that sustained reductions in driving pressure facilitated by extracorporeal support, or something like ECCO2R, may be the key to improved outcomes. And again, taking that one step further, reducing the intensity of mechanical ventilation as much as possible to prevent VILI as greatly as possible. We have experimental studies such as this by Areos and colleagues, showing that near apneic ventilation might be the way to go. So again, the idea that not only reducing tidal volume, but also reducing respiratory rate, leading to a dramatic reduction in mechanical power as well as driving pressure, could be the strategy to move forward with extracorporeal support as an adjunct. And again, because a picture is worth 1,000 words, you can see here on the right that in the sham group, where there was no injury, there's not much seen histologically, and the near apneic ventilation group had the most similar, or the least amount of injury, at least again histologically, especially when you compare it to the non-protective ventilated group and the conventional protective mechanical ventilation group, again suggesting that perhaps targets outside of just reducing tidal volume, or at least reducing tidal volume to a greater magnitude, leading to greater reductions in driving pressure, along with respiratory rate, may be the way to go here. This is nicely summarized in this left panel by Michael Quintel in this editorial, showing that when we look at that experimental study, that 75% of the reduction in mechanical power was due to a reduction in respiratory rate, along with some additions or gains from tidal volume reduction. So really reducing both respiratory rate and tidal volume might be the best way to reduce mechanical power, and that reduction in mechanical power might be the best way forward in terms of relation to outcomes. It's important to note that in the REST trial, although they managed to get tidal volume down, respiratory actually increased in the intervention group, and that might explain some of the lack of differences in results there. To do that, we might also need to rethink the amount of extracorporeal support that's being provided. These secondary analysis from the Supernova study, because a number of different ECCO2R devices were used in Supernova, some which had a lower degree of CO2 extraction, others that had a higher degree of CO2 extraction. And again, here the adverse events were actually slightly improved with the higher CO2 extraction devices, along with the ability to achieve the targets in Supernova, again, which were a reduction in tidal volume with the higher CO2 extraction devices. Now, if we're talking about moving forward to look at even more intense or higher magnitude reductions in the intensity of mechanical ventilation, we might need to focus exclusively on strategies or devices that can lead to higher degrees of CO2 extraction to get the intensity of mechanical ventilation, and therefore the amount of VILI protection, increased, to see if we'll be able to see an improvement in clinical outcomes. So what should we do next? I think, again, it's a coupling of both the mechanical ventilation strategy, perhaps looking at alternative targets like driving pressure and mechanical power, but also a different extracorporeal strategy. And perhaps the way forward, after learning from our pilot studies and the REST trial, that given that many of the risks for extracorporeal support are fixed, the need for anticoagulation, ultrasound-guided percutaneous insertion of catheters or cannula to connect to to extracorporeal support, and the main rationale is reduction in mechanical intensity or VILI prevention, then perhaps we should focus our efforts on using higher CO2 extraction devices, perhaps even all the way up to moderate flow VV ECMO, to maximize the potential efficacy of this strategy by reducing mechanical ventilation intensity as much as possible. And looking forward to the future, that higher flow extracorporeal support or other device innovations may also allow for a lower degree of anticoagulation, which is one of the main adverse events associated with the use of these devices. And that strategy might lead to obviously less adverse events. And perhaps some of these higher flow strategies, device patients may lead to or obviate the need for any anticoagulation at all, dramatically reducing the adverse events that might be associated with this kind of a strategy. So maybe just to wrap up, is the idea that moving forward, and what we've learned from our pilot studies and REST, is that to achieve a true alternative to breathing, to reduce VILI as much as possible, and to reduce mechanical ventilation intensity as much as possible, we need to optimize both our ventilatory strategy and how it interfaces with extracorporeal support. And again, these ideas are in no way new. There's a prescient paper by Ted Kolovo and colleagues back in the 70s suggesting that we don't even know if you need ventilation or positive pressure ventilation for optimal performance. That long-term apnea, so again, the near apneic ventilation with very low intensity mechanical ventilation might be the way to go to minimize, here again, the idea of mechanical power in these patients. That will especially difficult case. And the data suggests that perhaps that's the way forward in the field to get better results for our patients. So just to conclude, extracorporeal CO2 removal is a promising adjunctive intervention that could be beneficial in patients with ARDS to prevent VILI. Again, this is a combination intervention, so the interface with mechanical ventilation remains important in these patients. And based on our current data, we might want to consider alternative patient populations who may benefit the most, alternative ventilatory targets such as driving pressure and mechanical power, and strongly consider increasing the magnitude of intensity reduction, the dose, if you will, as well as the duration in which we apply it. We need more data for clinical trials before we could adopt this widely in patients with ARDS. We really need to understand the trade-off between potential efficacy and the important adverse events that have been seen, both again in pilot studies and in the recent REST trial. And again, we need to consider focusing our new trials on testing strategies with higher CO2 extraction to maximize the reduction in mechanical ventilation intensity and prevention of ventilator-induced lung injury. So with that, I want to conclude, and I want to thank you very much for your